Hi, good afternoon, everyone, and welcome to today's webinar, Working with Older Adult Trauma Survivors. I'm Jennifer Erf with the Massachusetts Association for Mental Health, and on behalf of MAMH, the Massachusetts Department of Mental Health, and the Massachusetts Aging and Mental Health Coalition, we're pleased to welcome you to hear today from Dr. Joan Cook from the Yale School of Medicine. Our webinar today will last 1 hour. That includes Dr. Cook's presentation and also facilitated discussion with our moderator, Rob Walker from DMH. Before we get started, I want to let you know that we are recording today's webinar. We'll send a link to the recording within a few days of the webinar, and you should feel free to share that recording with family and friends. We have a really full house today. We exceeded our registration limit of 340 people, and we have many people who wanted to join the webinar. So we hope that you'll share the recording, and as many people as possible will get to hear today's presentation. Because we have so many people on the webinar, you are in listen-only mode. If you have questions, please enter them in the question pane that is in the control panel on the right-hand side of your screen. If you can't see the control panel, click the orange arrow and it'll open up for you, and you'll see an arrow for where you can add questions. The questions will not be seen by everybody in the audience. They'll only be seen by me and the co-organizer, Elise Ressa from MAMH. Elise and I will coordinate those questions and we'll share them with Rob and Joan at the end of the presentation. So full disclosure to all of you, this is the first time we're using this webinar platform. We think that we've prepared everything exactly right, but some things may go wrong. So please be patient with us if we have to work through a technology issue as we go forward. And now it's my pleasure to introduce our moderator today, Rob Walker. Many of you know Rob from his work with the older adults and mental health communities in Massachusetts. He is with the Massachusetts Department of Mental Health's Office of Recovery and Empowerment, and he co-chairs the state's Elder Mental Health Collaborative. So Rob, take it from here.
Thank you, Jennifer. On behalf of DMH, I'm very pleased to be a sponsor of this webinar on trauma in older adults. And I'm very excited. I first met Dr. Cook yesterday, and I think that we're in for a great hour presentation. So Dr. Joan Cook is a clinical psychologist and associate professor at the Yale School of Medicine, Department of Psychiatry. She has over 100 peer-reviewed publications in the area of traumatic stress, geriatric mental health, and implementation science. And she's worked clinically with a wide range of trauma survivors, including combat veterans, former prisoners of war, men and women who have been physically and sexually assaulted in childhood and adulthood, and survivors of the 2001 terrorist attack on the World Trade Center. I'm very pleased to introduce Dr. Joan Cook. Thank you.
Thank you. Hi, everyone. Nice to meet you. I'm delighted to be here. I told Rob a little special something, that though I'm delighted to see all of you and meet all of you, my little auntie from Boston is in the audience. She works with older adults in a physical therapy office. So Rob just wanted me to give a special shout out to her. So hi, Auntie Kathy, thanks for coming. Okay, on to our work. Oops, okay, going back one. Okay, thank you all for coming today. Sorry, going back one, okay. I'm not sure if I'm controlling these or if Jennifer is. I'm just trying to go back one. I think I'm in control of them, Jennifer, but I'm not sure.
I think you are too.
Okay, I'm hitting backspace, but nothing's going. So I'm not sure if you're in control or I am.
Okay, let's try this again. It should be you, Joan. So let's try one more time.
Okay, if you could just go back one, and then maybe I can't go back, but I can only go forward. Is that?
Let me see if I can do that.
Okay. Okay, perfect.
How's
Thank you.
that, Joan? Do you want to just have me advance them for you?
Or I could try to do them, and then if we're having problems, then you could do it. Does that work?
Sure. It says
Okay.
you have control, so give it a try.
Okay. So again, hi everyone. I have been working in this field for 20 years. Older adult trauma survivors are near and dear to my heart, as I suspect that you are quite engaged in this area as well. What I'd like to do today, and I'd like to sort of present this in very detailed way, but also to go rather quickly so that we can save some time at the end for some Q&A. So I'd like to provide some information on the prevalence of trauma and its related mental and physical health effects in older adults. I'd like to discuss the importance of recognizing a trauma history in the older adults that you work with and really seeing through the trauma lens and explaining to why I think that's so important. And then to review some tips and strategies for serving and supporting older adult trauma survivors. I do not seem to be in control, Jennifer. So if you want to go, okay, great. So the first thing we thought we would do is get just a little poll so I could get a sense of how many of you are currently working with older adult trauma survivors and if you feel comfortable or know how to best work with trauma survivors.
Okay, so we'll launch our first poll, which is, are you currently working with older adult trauma survivors? And people are starting to vote. Okay, we'll take just a couple more seconds for y'all to respond. Okay. Still have a few more responses coming in. Okay, it looks like most people have voted, and Joan, about 70% of people said they are currently working with older trauma survivors. 15% said no, and 15% said they're not sure.
Okay, did you want to launch the next poll or did you want me to move
Sure.
forward? Okay.
Nope, sure, we can do the second one too. I know that's connected. So our second poll asks, do you feel comfortable and or do you know how to work effectively with older trauma survivors? And again, we'll take about a minute for people to respond. Okay. Got some of all of the answers.
Okay.
Okay, well, most people have had a chance to vote, so I'm going to close the poll. And Joan, it looks like about the largest answer is somewhat. About 52% of the people said that they feel somewhat comfortable. 15% said yes, 13% said not at all, and 19% said not sure.
Okay, great. Thank you. So it looks like the vast majority of you are working with trauma survivors and you feel at least somewhat comfortable. So hopefully the information that I'm going to be presenting to you is going to help you feel even more comfortable and skilled. I know we have a limited time today. At the end of the slides, I also provide you with my contact information. Feel free if there's any articles that I talk about or that I mention, I'd be happy to share them with you. Okay, Jennifer, if we can go to the next slide.
Sure.
Okay, So why do I think this is important? Why do so many of us in the field think this is important? Well, we all know that there's a graying of America, but sadly, relatively less is known about trauma in older adults. And that could be for a number of different reasons, which we're going to talk about in a few minutes. But there's much less research and clinical work written in the scientific literature about this population in comparison to, say, kids or adolescents or younger or even middle-aged adults. We just don't have as much knowledge, sadly. So I'm hoping some of you will want to join me in this endeavor and write some interesting stuff up and help educate the field. So I think, you know, it's probably under-recognized by the older adult trauma survivors themselves, which we will talk a little bit about. But it's also probably under-recognized by a lot of frontline healthcare professionals. I was saying this to Rob earlier. I think sometimes when we think of trauma in older adult populations, a lot of us have the stereotype of an older combat veteran. And while that's true, that is only a small slice of the older adult trauma survivor pie. I think if we don't recognize this and our patients don't recognize this, they're likely going to be undertreated or even treated for something else, but not PTSD or depression related to their trauma. And so I think this lack of recognition, or what I call a misattribution of symptoms, can have some serious health effects for our older adult population. Next slide. Okay, so I know that other people describe trauma differently. I know that this is different than the definition given from SAMHSA. I am in appreciation of that for sure. I sort of, you know, in my research and in my clinical work, I use the American Psychiatric Association definition of a traumatic event, which tends to be a little more stringent, I realize. Sometimes I think of it as sort of like big T trauma as opposed to small T trauma. And of course, knowing that there's always a subjective component to that. So the definition, and I'll just go over this briefly, the definition of a traumatic event per the Diagnostic and Statistical Manual, version 5, says that in order to experience a traumatic event, you had to have actual or threatened death, serious injury, or sexual violence in any one of the following ways: direct exposure, witnessing it in person, learning of events occurring to a close friend or a family member, but it must be violent or accidental. So normative adult changes like losing a spouse in older adulthood, while very distressing potentially, would not be seen as a traumatic event according to the DSM, and therefore we wouldn't assess for PTSD. I know that's not how some of us roll. Or the last traumatic event according to the DSM is repeated extreme exposure to aversive details of trauma. So police officers, first responders, the healthcare workers, certainly in these COVID times, especially in places like Massachusetts and New York City. Next slide, please. So PTSD, never before since it's entered our diagnostic nomenclature in 1980 have we seen such changes to this definition. So when DSM-5 came out, there are no longer 3 symptom clusters, there's 4, and these include re-experiencing, avoidance, negative cognitions and mood, and arousal. I'll just briefly give you a little snippet because I so much I'd like to cover with you today. So re-experiencing means that a trauma survivor has an intrusive memory. It's not something that they want or invite in. It sort of comes at any time it intrudes upon their life. They could have flashbacks as if the event were reoccurring, and then they have physiological or psychological distress when they expose to reminders. Avoidance, for a lot of us in the mental health care field, we believe that avoidance is one of the things that maintains PTSD symptoms, and that people are they want to help themselves. They're very well intentioned, but what do? When the trauma memories come up or the trauma reminders, they sort of push them down. So they try to avoid memories, thoughts, situations that would remind them. And we believe in the theory of PTSD that then maintains the PTSD symptoms. So one of our therapies, or a lot of our therapies, work at sort of processing the trauma. Negative cognitions and mood. This can involve excessive self-blame, distorted thoughts about yourself. You know, trauma, as many of you know, changes the way you think about yourself. It changes the way you think about and feel about other people, and certainly about the world. This can also, too, feeling like other people don't get you. You feel kind of estranged or have difficulty trusting and feel very emotionally numb. For a lot of the people that I work with, sadly, if they do experience intensive emotions, it's usually kind of the yucky ones, as opposed to feeling sort of joy and life satisfaction and engagement in living. And then arousal. Many of our older adult patients with PTSD have a hyperarousal, an exaggerated startle. If we come up and tap them on the back, they feel like they're going to jump out of their skin. This can also mean that they're always scanning the environment, looking for danger. This could also include problems with difficulties in concentrating and insomnia. Next slide, please. So I thought I'd just give you two little snippets of two patients, older adult patients, that I had the great fortune of working with. I was going to describe an older combat veteran because that has been one of my specialties for the past 20 years, but maybe I wrongly assumed, but I assumed that many of you have sort of, you know, heard about older veterans before. So I thought I'd do something and share two fairly unique cases for all of you. In my opinion, and I think the data shows that sexual violence in our world is a global public health problem. And though I feel that the Me Too movement has put this on the map for women, I feel that we haven't done enough for male survivors. And so I'm going to talk about a male survivor that I've worked with, and I actually have a grant right now on male sexual abuse survivors. So I think most people don't know that at least 1 in 6 boys experience some kind of sexual violence by the age of 18, and across the lifespan, that number is even higher. 1 in 4 men experience sexual violence. They are perpetrated against across the lifespan. So this was a gentleman that I had worked with. His name was Ron. That's not his name, but that's the name I'm using. Ron, he was a 67-year-old, never married, non-combat US Army veteran with severe chronic PTSD. It was related to several lifetime sexual assault incidences perpetrated by men throughout his lifetime. During his childhood, his father repeatedly sexually abused him from ages 6 through 11. He was raped by a stranger in childhood. He was also raped by an uncle. He had also experienced witnessing domestic violence between his parents and physical abuse by his father. During his adulthood and after his military service, he was sexually exploited by an employer in exchange for food and housing over a period of 7 months. And he actually worked in the sex industry for a limited period of time. By the time he came to my colleagues and I at a local VA, he had been through a number of different treatment programs, but everybody was focused on the substance abuse. And almost everybody, until the referring physician, had ever put the pieces together about his sexual abuse history. And I think one of the things that I sadly took from this is, if we don't ask, older adult patients typically don't tell. They're not going to generate that information. So that's a little bit about Ron, and I have written up with my case vignette if you're interested. Next slide, please. Okay, before I was at Yale, I had the great privilege of being at Columbia, where I had worked with people who had escaped the towers or were first responders. I'm going to call this client's name Mary. Mary was a 72-year-old Irish Catholic widow who presented to her primary care physician with difficulties concentrating and sleeping, a general sort of nervousness, and increased heart palpitations and sweating. After numerous diagnostic procedures ruled out any medical illness, Mary's physician probed into her history. And in doing a very thorough assessment, really found that Mary had lived alone in a high-rise building below Canal Street in Manhattan, near the former World Trade Center. And Mary's apartment had a really close view of the former Twin Towers. And one of her greatest daily pleasures in life was watching the comings and goings of passerbys. And on the day of September 11th, 2001, Mary diverted from her usual mid-morning routine of attending a local senior center, and she remained at home to do some, light house cleaning tasks for herself. And when the first plane hit one of the towers, Mary reported hearing a deafening noise and felt the ground shake beneath her. And from her window, she witnessed the first tower burning. And Mary described being mesmerized, like she was in a trance. And she couldn't take her eyes off the building. She watched in horror and disbelief as a second plane hit the other tower, and then victims jumped out of high windows to their death, as many of us saw as well. And finally, she saw both of the towers collapse. She heard the sirens and people screaming, and shortly thereafter, there was a very intense dark dust. Mary typically wore hearing aids, but the morning of September 11th, she didn't have them on. So it was possible that neighbors or the superintendent had tried to knock on her door and help her, like evacuate the building. But if they did so, she did not hear them. And so her only daughter had moved to South Florida the year before, and Mary had no immediate family or sort of what you might think of as sort of a capable support person living nearby. And between the breakdown of the communication and the telephone and the wireless phones were interrupted, she had an inability to get out, and she was in what we call the frozen zone, the area near the terrorist attack and where the blockades were set up. And so she waited in her apartment, terrified, for 3 days to be rescued. So those are the big T traumas that my presentation is really planned on. So a little bit about the prevalence. By the time most of us get to older adulthood, we've experienced usually at least one big T trauma. In certain older adult populations, like veterans that I've spent so much time with, like Holocaust survivors, like refugees, the rates of those traumatic events are even higher. Next slide, please. Okay, surprisingly though, the rates of PTSD are not very high. This always shocks me, and we'll talk about why this may be. So the rates of PTSD, these are in large epidemiological studies in the US, really show that the rates are about 2.5 at most, 6.5. Compare that number to what it is in the general adult population. It's sort of 8 to 10%, so it's lower. A number of my colleagues and I have done some investigations and sort of looked at, maybe some of the older adults are not endorsing the symptoms, and we'll talk about that in a minute. Maybe what we need to is that the symptoms change over time. So maybe what we need to look for is maybe not full-blown PTSD, but maybe a partial PTSD or sub-threshold PTSD. So please consider that when you're doing your assessments. I'd be happy to send you measures. Next slide. I'm sorry, next slide. Yeah. So this is really fascinating for me, and I think for all of us, I think it's important to keep in mind now, especially because of COVID. Most people that experience really bad events do not have full-blown PTSD, and there are risk and protective factors that I could share with you during the Q&A that sort of can buffer people to experiencing PTSD. But after a traumatic event, there seems to be at least 4 trajectories of mental health. So one is, let's do the recovery route first. Most people experience some symptoms afterwards, after a really horrific event, but over time, they recover. Now that may be for a number of reasons, but there's also sort of like a natural healing process that sort of happens with people, and most people recover over time. Some people, God bless them, I wish I was one, experience relatively few symptoms after a traumatic event, and then maintain that. And we call that resiliency. I know Rob and I had also talked about post-traumatic growth, and we could sort of talk about that in the Q&A too. There are some people who have some symptoms after a traumatic event, and then over time, whether it's because of the passage of time or undigested memories or maybe triggers that happen in their environment or other major stressors, they have like a delayed reaction. And then there are those among us who have intense symptoms after a traumatic event and continue to have more of a chronic course. And this might help you in identifying the problems that your patients are having, which sort of trajectories, because how we might approach them would be different. Next slide. So some of us have argued in the field that trauma is likely a hidden variable in the lives of older adults. You know, it didn't enter our diagnostic classification system until 1980. So when many of our older adults were younger, there was a lack of recognition for traumatic events. We certainly didn't know what PTSD was. It wasn't until the Vietnam veterans and the women's movement sort of, you know, collided in the 1970s and sort of put it on the map. It was always sort of talked about in the literature, but it really wasn't on our clinical map until then. We think it might be also a hidden variable because sometimes older adults, maybe based on their sort of deficits in recall, or maybe because of the PTSD symptoms of avoidance, they don't want to go there, that they're not sort of telling us about them. Or there is some data to suggest that those who have had PTSD tend to have higher mortality rates. So perhaps some of our older adult trauma survivors are dying before they reach old age. Next slide, please. So why are there higher rates? And I'll try to hit this quickly so that we can move on to the tips and the strategies. Maybe younger individuals admit to more symptoms because there's fewer stigmas for that for their age group. Maybe they're better able to identify psychological problems. Maybe older adults, and I'm sure all of you have had this case where older adults will say like, you know, oh, my nerves are bad, or, you know, they describe it as like headaches or somatic symptoms like pain in their stomach. And maybe we need to teach them and educate them about the signs and symptoms of PTSD and normalize it for them. Maybe there's also that some of our older adults sort of have a lack of familiarity with clinical interventions. Next slide. Okay. I think too, and I've seen this a lot, I'm not sure if you've seen this a lot, I'm going to share just a couple little snippets here. I think the disclosure experiences, I think it's still hard for people to disclose traumatic experiences, and they don't often get what I might call the most supportive experiences. Afterwards, people tend to minimize or blame. And I think, you know, our society didn't sort of discourage people years and years ago, and still somewhat today, from speaking out against violence. So here's two patients that I had the great pleasure of working with. I'll tell you one, and then I'll weave the other one in a minute. I worked with a World War II combatant and former prisoner of war. I had the great privilege of doing so on my internship and postdoc at the Palo Alto VA in Northern California. This was an incredible man, and I ran a large psychotherapy group. And he said that when he came home, he had two negative disclosure experiences, which really shut him down for years. One was that he came home and he had been diagnosed as having frozen feet. And frozen feet, if any of you know, is permanent nerve damage. But when he came home, the older physician, the physician who was working with this gentleman had said to him, oh, you're back in sunny California now. You won't need this disability for frozen feet. And they took away his disability, his compensation for that, misunderstanding that it had nothing to do with the weather. The second disclosure experience that this man had that really shut him down for years, and then he went sort of into his bunker and suffered for silence for decades, is that a family member said to him, why did you give up? He was in the European theater. Why did you surrender to the Germans? And he was so pained by that. He had so much PTSD and self-blame already that had been captured, and it sort of, you know, just minimized his pain even more. And so decades later, he said to me, Joan, what I really wanted to say was you would go too if you had a German Luger, which is a gun, at your head, but I couldn't. And so I think those negative disclosure experiences, if they've tried to tell us about those experiences, unfortunately, even if some of us are well-intentioned, we tend to not provide the right supportive context to support the disclosure. Next slide. Okay, I think there's also other sort of language and other barriers and why we see lower rates in older adults compared to middle-aged or younger adults. One, I think, you know, the language that we use. I remember years ago, again, in Northern California, doing a study on older women and asking them questions and not knowing what I know now. And we were asking and assessing for trauma. And we were asking, you know, have you ever been raped? Have you ever been sexually assaulted? And I remember this one woman in particular who would have disclosed it if I had appropriately asked the way that she had identified it. And she said, no, I've never had any of those experiences. And we sort of wrapped up the interview and I was getting ready to leave. And then she said, well, and she started to describe marital rape, but that was not the language that she had to describe, you know, the experiences of assault that she was having by her husband. And so I think, you know, for this population, we need to use specific terminology as opposed to some of the more colloquial terms that we use today. I think sometimes the normal aging process can change PTSD. For example, if you're hyper aroused and you're easily startled, if you start to have hearing problems, you may not have those symptoms anymore. And that's just one example. I think sometimes we talk about that there was a wisdom of aging and that the passage of time may heal old wounds. Next slide. So I want to talk just briefly before we talk about strategies about the course of PTSD and other negative consequences. Next slide. This is one of my favorite studies, and there have certainly been better ones done today, but this was a study done in 1989, and I think it really speaks to the need of older adult trauma survivors to be heard. So this was a study based, it started in Northern California, and these two psychologist researchers went to a former prisoner of war meeting, handful of men in the room, and they asked them to fill out a survey, asking them about their PTSD symptoms across their lifespan up until that point. And these gentlemen were so desperate and wanting to be heard and wanting to represent their community that they photocopied these surveys and sent them all across the country to their friends. And they had thousands upon thousands of people responding. And what it looks like they found, and this is retrospective, it's not prospective, right? So this is what they remember and thus report. It looked like at least 20% were continuously troubled in that sort of chronic trajectory that we talked about. It looked like 20% were symptom-free, so those would be the resilient ones. And then it looked like about 60%, the majority, experienced sort of a waxing and waning across their lifetime. Next slide. So why do we think that is, and what predicts the ebb and flow? Again, not great data on this, more clinical lore than anything, and you folks might have stuff to sort of add at the Q&A. I think it's related to, you know, changes in life and losses, and certainly anniversary reactions we see a lot. But I think in particular, when you talk about aging, you know, we have an increased risk for medical illness, decrements in our functional status, bereavement, retirement, changes in our social or our familial roles, our loss of control. We have a lot more time to reflect. I think this to me represents sort of a vulnerability. I think a lot of the older adults that I've worked with for years, when they've hit old age, they've somehow managed to cope with their symptoms more effectively throughout their life. Let's say a lot of the World War II veterans or the Korean War veterans, for example, that I had the great pleasure of working with, would overwork. They would work 2 and 3 jobs. So by the time they came home, they would just pass out in exhaustion. Or I've worked with a number of older adults who would engage in sort of woodworking or to cope with traumatic anxiety, or reading. They'd come home from work and they'd read the newspaper, they'd read Louis L'Amour. And then as they started to age, when they became arthritic or they had failing eyesight, then all of a sudden there went their coping strategy for dealing with their symptoms, and we began to see more of a flood of symptoms. Next slide, please. So some people say, well, is this delayed onset then? They never had the symptoms before, or is it delayed recognition on their part? They never were able to put the pieces together, or now providers are starting to ask for it. Or is it partial PTSD that sort of worsens over time? We don't have the exact answer. I think it might be better conceptualized as a reemergence, or an intensification or delayed recognition, as opposed to delayed onset. Now, I do clinical work and I do research. I've never seen anybody who's had full-blown delayed onset for the first time in older adulthood from earlier or early adulthood trauma. It's possible, but I'm not sure if it's probable. Next slide, please. And of course, I think, you know, once somebody wears the diagnosis of PTSD, they rarely wear it alone. There's a lot of things that people do in court, in particular, substance abuse. You know, a lot of people are very well-intentioned. They try to cope with their symptoms the best they can, and drugs and alcohol are extremely effective, especially in the short run. We know over the long run, not so effective, because now you have not just one disorder, but you have multiple disorders and other problems that go associated. But PTSD is rarely worn alone. People have other mood, anxiety disorders, alcohol, and substance abuse. They also have a history of lifetime suicide attempts and suicidal ideations. Also lower sort of what we think of as sort of psychosocial functioning, pain. They also have poor relationships. This was a study that I did a long time ago on older ex-prisoners of war, and talking about the relationships they had been in, and people saying, I never disclosed the history to my wife or my partner. I never disclosed the history to my children, and having a lot of difficulties sort of with trust and communication so many decades after the traumatic event. Next slide, please. In addition, you know, I think sometimes our older adults get sort of, trauma survivors get marginalized because they say, well, you know, they just think they're sicker. It's their mood that's impacting how they feel. And in self-report data sets, we certainly see that older adults describe themselves, you know, their self-report, their physical health, as being sicker. But the interesting thing is, when you go back and you look at the charts, and there's been some great work done by Paula Schnurr at the VA's National Center for PTSD at White River Junction, Vermont, really showing that if you go back to people's clinical charts, those with PTSD have many more physician-diagnosed disorders, from gastrointestinal to musculoskeletal. So it's not just in their head. They're actually physically sicker by a physician diagnosis. And I think this is also some interesting studies that's coming up. And again, you know, PTSD didn't enter our classification system until 1980. We now know that people who wear the diagnosis of PTSD, especially for years, have a greater risk for dementia and cognitive impairment. I realized at the time I probably need to go faster. I apologize. And sadly, I'll just say that older adults don't often get the help that they need. They have lower rates of adequate treatment, fewer therapy sessions, longer periods of time to wait for help. Next slide. So here are some tips and strategies about serving and supporting older adult trauma survivors. Next slide. I think the first thing we could do is sort of look at it from a trauma-informed to a trauma-responsive continuum of care. The first is for us to be aware of the prevalence of trauma and the potential it could have on our patients' impact, and see things through the trauma lens. A next step on the continuum is to really normalize patients' reactions to the trauma, educate them about trauma, and make it sort of destigmatizing for them. I know so many older adults that we work with feel like they're lazy, crazy, bad, damaged goods, that they would have these symptoms and signs of PTSD, when you and I know that they're very common and it's normal. And then we can screen for trauma, screen for PTSD, and actually treat the effects. Next slide. Okay, so I was on the American Psychological Association clinical practice guidelines for the treatment of PTSD, where we reviewed hundreds of randomized controlled trials. There were a number of therapies that we said that were sort of strongly recommended based on the effect sizes and the quality and the methodological rigor of the studies, and some that we suggested were conditionally recommended, but these are some of the top ones for you. You could see there's a real sense of sort of a cognitive behavioral angle, and I should just say that's what tends to be studied. So it's not that what you might be doing or favorite therapy you have isn't necessarily helpful, but that perhaps we haven't studied it. Next slide. So these are the three big ones, I think. Certainly two of these have been widely disseminated, particularly in the US Department of Veterans Affairs, prolonged exposure and cognitive processing. They both have components of sort of a trauma processing. I won't go through all of them here, but I can answer some questions in Q&A, and eye movement desensitization and reprocessing. So I would say these are sort of the three biggies. There are some free online courses for PE and CPT that I could certainly send you that you can get course credit for. I don't know of those for EMDR. Next slide. But there, oh, sorry. Do you want to do the slide, Jennifer? Okay. So we'll just skip the slide because I think I'm being too verbose, and I apologize. Too many things I want to tell you guys. So there's lots of things we could do when working with older adult trauma survivors. Sometimes we need to think about their cognitive abilities beforehand. If they're cognitively intact, there shouldn't be any intervention you can't do with a younger adult that you could do with an older adult. You know, it's psychoeducation, relaxation training, development of coping skills, mindfulness-based interventions, cognitive behavioral therapy. Next slide. Certainly a lot of meaning making can be done. This was a great and sort of classic book about shattered assumptions that was written in 1992. We talked just briefly before how trauma changes people, how they think about themselves, the world, and other people. And it's important to help people think and feel differently. Okay. And to, you know, renew their sense of meaning and purpose. And I sort of think of that classic book of Men's Search for Meaning when I think of meaning making. Next slide. And then also sort of fostering reconnection. I think there's a lot of times people feel disconnected from themselves. They feel disconnected from other people. Sometimes people feel like they need to make amends and forgive themselves and re-engage with meaningful activities. There's a great model of trauma therapy that I just love. It's from Boston. Of course, Boston's good for everything. It's a great book called Trauma and Recovery, and it's by a classic seminal psychiatrist who really started the trauma psychiatry psychology field named Judith Herman. And she talks about this 3-stage model. And this last stage is about reconnecting with aspects of ourselves that we lost or were never fully able to develop. It's a great book, a must read for all of you. Very accessible read too. Next slide. So I think some special considerations for working with older adult trauma survivors, we need to think about the effects of cognitive impairment, whether they're residing in long-term care facilities and end-of-life issues. I'm almost done, I promise. Next slide. So potential modifications for people in early to moderate cognitive decline. Maybe we need to go at a slower pace. And help with additional sort of repetition for encoding and retaining the information. Oftentimes we need to be more flexible, but you guys know all this, I'm preaching to the choir, in terms of our scheduling and our location, and we need to maybe involve caregivers. I can send you more modifications after. Next slide. I think it's really important, especially when we get to long-term care settings and we think of people who potentially have some cognitive impairments, that we need to not try to educate them, but try to do something differently ourselves. And I think that what my colleagues and I have tried to write about is for us as healthcare providers to recognize what are the triggers for these trauma survivors, and then for us to sort of change our behavior, and whether it's certain sounds or sights or even staff activities can all be potential triggers. So how do we change so that they don't get triggered and have some PTSD symptoms? Okay, next slide. So this was some work that I did back in 2001 with some colleagues. And this was sort of based on working with older combat veterans. So some triggers could be authority figures or people having, a lot of VA hospitals. We have a lot of VA sort of, paraphernalia. Sometimes that could be upsetting to people. So removing the trigger. We talked about before about hyperarousal and people sort of feeling like they're going to jump out of their skin. So don't approach an older adult from behind and tap them on the shoulder. Come up from the front, make good eye contact, approach them in a calm manner. I think Jennifer and Rob had made this as a handout for any of you, and I'd be happy to answer questions at a later point in time. Okay. Next slide. And so I think at older adult trauma survivors at the end of life, personally, I wouldn't aim for doing an evidence-based psychotherapy. I think, we might see PTSD symptoms reappear. I think what we need to do is be human and listen and validate and focus on their strengths and help them with meaning making or amend making, and educate family and staff what they may be going through. And then to also do sort of those reduction of the trauma triggers. Next slide. Just wanted to do one shout out about this, and I think it's so important. I'd be happy to send you materials. Is we need to think about, to be good providers, we need to think about our own care. This is really hard work, and it's really rewarding too, but it can be really challenging, and it's so challenging that it actually has a name. And working with trauma survivors across the lifespan can really impact our personal and our professional well-being, and it's called compassion fatigue or vicarious traumatization or empathic strains or burnout. So please, as you do all of this work, particularly as you do all of this work where many of us, myself included, are very jacked up with COVID anxiety, that you take good care of yourself. Yeah, that would be my wish for all of you. Next slide. So thank you for listening. Thank you for taking care of older adults. If you have any questions or comments or want any of the articles, I'd be happy to send you stuff. That's my email address. Okay, Rob.
Thank you so much, Joan. You must be out of breath. That was.
I'm sorry, I tried to go quickly.
No, that was great. That was a great overview of trauma, and I was really struck by your comments about working with older adults and story making and making sense out of their life. There's several programs at the VA, My Life, My Story, about sort of making sense out of your life and making sense out of the final chapter. And I think that has a real key, and it's something that all of us can do. We don't really need that expertise in clinical skills to help people with that. But you mentioned COVID-19, so I was interested in your take on how the COVID-19 quarantine and anxiety and all that has affected trauma survivors, and what that might look like in a trauma survivor who's an older adult.
Okay, great question. Of course, I always have to say I have no data on that. This, it's such a new phenomenon. We don't have great data, but what I'm sort of hearing, what I can imagine, one of the things that triggers trauma survivors across the lifespan is not feeling in control. trauma takes away their power and their control, and that becomes a real trigger. So I think, you know, COVID totally feeds into that, sadly. And that one of the things that we can do is really help people with sort of a physical or sort of psychological safety, the best we can do, from a thorough assessment of what their needs are and helping to meet some of their needs, to sort of teaching them, you know, good, healthy hygiene from the CDC to sort of reduce the risk of infection. I think there's also ways that we could sort of cultivate calm in these older adult trauma survivors to help them stay, you know, grounded, or try to stay grounded.
Yeah, thank you. And I've heard a lot from colleagues that work with people, especially from the Eastern European countries, about all the hoarding and all the lines waiting for food that's not there in the store, and all that is bringing back a lot of memories of their growing up in the communist countries. So that's another thing to be aware of. But I think Jennifer had a couple questions from you all in the audience. If you want to read those, Jennifer.
Sure. We actually have a whole bunch of great questions from the audience. I'll add my video here. So one of the questions is from Marianne, and she asks, is experiencing a cancer diagnosis and treatment and surviving after being given a 50-50 chance considered a traumatic event?
There's certainly plenty of people who consider that a traumatic event. And according to the DSM, it would meet criteria. I think, you know, it also, although, you know, the DSM is sort of an objective measure, I think there's a lot of subjectivity to it. So, you know, some people may not consider that, but if the person that you're working with feels that it is, then absolutely. I would never want to minimize someone's pain and say, no, according to the DSM, you know, we don't want to invalidate anyone. Trauma is very invalidating. So does that answer the question?
I hope so, and I think it's a great time to also add a comment that that we received from Joe with a shout out to peer specialists, saying this is why the work of peer specialists is so important. We are humans first, last, and always, and I think that really connects, Joan, to the last comment that you made, the last answer that you just gave. So we also have a question from Mary. This is a hard and a tricky one. Everyone be ready. Do you think there could be a decrease in tolerance for stress and acute stress situations in younger generations? That is, that they feel distress, that for them to feel distress is to be traumatized, while older adults see distress as part of being human.
Ah, interesting, very interesting. Very interesting, the generational effects that could be in the cohorts that we sort of grew up with, you know, people sort of living through, you know, the Great Depression and World War II and going without and being sort of resilient, where it seems like now with all the helicopter parenting, children aren't even allowed to develop their, you know, strong sea legs. So perhaps I haven't thought that much about it, but I will. I've been writing these op-eds, I think I told you about, for the past couple of years. That's one I'm going to put my thinking cap on and try to digest, and I'm not sure, but it sounds good what Mary said.
Right.
Yeah.
Great. And we have a question from Jennifer asking, have you had any experience working with someone who was diagnosed with conversion disorder? And what are your thoughts around this and how to support someone who's experiencing that?
Just looking at the time. So yes, I've worked with people who have conversion. I've also worked with people who've had dissociative identity disorder. You know, I think, you know, the disorder that is most affiliated, people think, is PTSD, but there are so many other, you know, as we talked about, in order to cope with trauma, a lot of people turn to substances. and drugs. So there's a lot of different things. One of the best people to work with dissociation and conversion is a woman named Bethany Brand at Towson State. So I can send you some of her stuff. But yeah.
Great. So this is just, it's an observation from Anna, but I think it's really important, so I wanted to share it. She says, as a trauma and PTSD survivor, one thing I think we should realize is we were, as young people, searching for help and were dismissed, told we were hypochondriacs or attention seekers. We were told that's life, so just get over it. Now with the people I work with, they feel that they should suck it up, that people should just suck it up and be strong. It's hard for them to be, that makes it hard for people to be forgiving of themselves. So I don't know, Dr. Cook, if you have any comments or.
Absolutely. I could say that on a bullhorn. That's so, for a number of the World War II and the Korean War guys that I used to work with, they came back and they were told them, to put it all behind them. And so they very much espoused, the John Wayne mentality. I'm going to go forward, and without recognizing and acknowledging their pain because they weren't allowed to. And I think that's exactly right, sadly, and that we need to now ask people about their traumatic experiences in old age, how that might have impacted them, and normalize and educate them. I remember one 80-year-old World War II veteran, when I was at the Philadelphia VA, a physician had assessed PTSD for them for the first time, and he came to my office down in this dank basement, and I just assessed PTSD simply asking some questions, and he bawled like a baby. No one had ever talked to him about that. So sometimes simply that education and that normalization can do wonders. And as Rob said, we don't need to be licensed psychologists or social workers. We're just be human. And there's some great online materials. I can send you guys some if you want to pass them to the participants, sort of educating people about PTSD and normalizing it.
That would be great, Joe. And if you share that with us, we can share that with the group when we send the recording link in a few days. Great. We have just a couple minutes. Can we squeeze in one more question?
I'm okay, yeah.
Okay, great. Well, we have a question from Mary, and she asks, are there any suggestions about preventive measures we can employ now with older adults with whom we work?
Preventive measures so that they don't have an exacerbation of PTSD, or I'm
not sure, but I think the context is for people who have trauma histories and now are enduring what is, obviously a really scary time for people, but especially older adults with the COVID crisis.
Got it. Okay, so I think that goes back to what we were talking about with Rob, is sort of thinking about ways that we could help them cultivate calm. I don't know if that's a term, but it should be. And so I think when we work with them, we don't want to pretend that COVID isn't serious. It is serious. I think we want to make sure that they are aware of and most up to date about the knowledge that we have, normalize any reactions they might be having, put it into context and linking it to trauma and explaining this is likely re-triggering for them. And then I think to promote like a sense of control. And I know that that's hard to do because many of us feel like we have no control. We don't know what's going to happen in the future, but ways to do that. And sort of, what they can control, small sort of problem solving, set achievable goals. Do they have access to the internet? Do they have food? Do they need food delivered? Those kinds of things. And helping them get set up with things that they can feel control about. And maybe even, educating and normalizing it's normal when we feel so out of control for trauma survivors to, feel on edge, understandable. It actually is stupefying to me that they wouldn't feel that,
Right. Well, Dr. Cook, that's a fabulous way for us to end. I am sorry that we're out of time. We still have some more questions, and I'll look at those and see if we can integrate some answers into the follow-up email that we send in a few days.
enthusiastic about this topic that I
We
talked.
are so glad.
No, this is
We
great.
are so glad. And we
Feel free
could,
to send me email and ask questions. That's fine.
well, and the overwhelming response to this webinar, the number of people who wanted to participate really shows how important this is to people. So we are so grateful for you to be here. Rob, before I close the webinar, did you have any last words or thoughts?
No, I think trauma in older adults is really an unexplored topic, and hopefully we can continue the series, and hopefully we might get Dr. Cook back for some additional webinars. But thank you everybody on behalf of DMH.
Great. Thank you, Rob. Very special thank to Dr. Joan Cook for being here today. Thanks to everybody on the webinar, and especially those of you from the Massachusetts Aging and Mental Health Coalition and the Planning Committee who helped to develop this. And I hope some additional educational webinars on older adults and trauma in the future. After you exit the webinar, you'll get a pop-up with just a couple questions, evaluation. I hope you'll take just a minute to respond to that. And again, on behalf of the Aging and Mental Health Coalition, MAMH, and the Massachusetts Department of Mental Health, thank you for joining us today. Have a great rest of your day.
Thank you.